Hello everyone, good evening. This is Dr. Shaher Khan. It's a pleasure to be on and to discuss with you the very important topic of breast implant illness. It's a pleasure to be on again on one of these lives where I can discuss with you my experience as a board certified plastic surgeon in regards to my practice. My practice is exclusively devoted to removal of silicone implants, saline implants, and residual capsules. And this is essentially exclusively what I do so that I can share my knowledge and discussions with you so that what I practice on a daily basis I can discuss with you so that you can learn and enhance your experience. I'm blessed to have had a very past productive few months, and again learning from my patients. I see and I learn on a daily basis. So just today I finished a case a few hours ago where a nice lady, 32 years of age, she comes to me from the Northeast with bilateral breast implants that were silicone below the muscle from 2016. So just 8-year-old set of silicone implants. These were textured, and she had a very, what I use the word, benign exam, meaning you would look at the exam, and I even documented no hard facts suggestive of what is a breast implant rupture. And she had no contraction, overall no pain. And this is what I call a silent rupture. And lo and behold, to my surprise and to the patient's surprise, the left breast implant was indeed very much ruptured. And this is again where the surgeon has to always assume that the implant is ruptured till proven otherwise, and that the whole gist and essence of the surgery is to remove the entire implant and the capsule and all of that inflamed tissue completely, sincerely, definitively above the rib, directly on top of the rib, underneath the pectoralis muscle, such that the fascia of the pectoralis major, pectoralis minor fascia, fascia of the serratus anterior, the periosteum, and the perichondrium, that's the layer directly on top of the rib, is removed, which essentially ensures that the entire implant capsule and inflamed tissue is removed. Normally, below the muscle, there is really not much of a tissue except for the connective tissue, so there is really no volume that is removed. The breast tissue above the implant is essentially left untouched. There is no up and down incisions. These are incisions that are made only horizontal, right in the crease, incisions that are going to hide in the crease. And the dissection essentially is done right underneath the muscle, such that the entire implant capsule and that inflamed tissue around is going to be removed completely, definitively, such that there is no inflammatory burden left behind. And that is essentially the essence and heart of what is explant surgery. This is where, just like me, I was pretty certain just going into my surgery that the implant was going to be intact, the right and certainly the left, and lo and behold, to my surprise. So when the surgeon has to always assume that the implant is ruptured till proven otherwise. If you look at the manufacturer's warnings, they recommend in their brochures that patients get an MRI at year 3, and then every 2 years they're onward looking for what is a silent rupture. Silent rupture meaning that the patient is not aware, neither is the surgeon, and there's only ultimately 2 ways to figure it out: to get an MRI without contrast, which I don't make my patients get all the time, and the second thing is that the surgery is done only to find out that the implant is ruptured. So as I normally do, I return the implants to the patient. I always send the capsules off to pathology to make sure it's not the BIA-ALCL, CD30 analysis is done, BIA squamous cell cancer is ruled out, breast cancer is ruled out, and that cultures are done for fungus and bacteria, aerobic, anaerobic, and fungal. So just to kind of highlight how I do it in my practice, there is essentially a list of 7 things that I exclusively do all the time consistently from one patient to the next. Number 1, I return the implants to the patient, be it ruptured or not. Number 2, I take cultures for aerobic, anaerobic, and fungal bacteria because that's important to rule out. Number 3, I essentially do not place drains. I have not placed drains in well over almost 5 years now, and the many implants that I've placed simply because the blood loss has been essentially minimal. Number 4, I do not do a lift because majority of the times, well over 80% of the time, the patients do not need what is that unnecessary lift. Number 5, I take high definition pictures and videos of the chest wall showing complete removal of the capsule, and also me cutting open off the capsules on the table once the patient is closed, and high definition pictures as well showing that complete removal of the capsule was done. No matter what the age of the patient, so just recently I operated on a 73-year-old patient. She got the same surgery that the young patients get. The 23-year-old, for example, I recently operated on. Now, also very importantly, I discussed with the patients that this is the twilight anesthesia that I do, which is where the patients get propofol, fentanyl, Versed, and patients are not given what is the general paralytic anesthesia because that is not required. I have used it at times, but vast majority of the times it is the propofol, fentanyl, and Versed, and the patient to date, as you will see, not a single patient has had any recollection of the surgery. And so that is very safe and very effective anesthesia. And so this is where essentially what and how my practice is, and I've done it consistently in the many patients that have come to me. So just real briefly about my patients in the last few weeks. I saw a patient today. She came from Texas. She had 700 cc implant on the right and 650 cc implant on the left. And the way I cut out that excess skin at the bottom of the breast chest area, where the implant was essentially functioning as a tissue expander, this patient, a young lady in her 40s, actually did not need a formal lift and only a horizontal incision, such that the entire implant and capsule and all the inflamed tissue was removed, and her young skin actually recoiled very well to the point where just in the 6 days now that she's been here, she did not need that unnecessary lift and certainly did not need those unnecessary drains. Now remember, the entire explant surgery is done in vast majority of the cases below at the level of the rib, which means at the basement level, if you will, right on top of the rib, removing the fascia of the rib, the periosteum, perichondrium, that's the layer directly on top of the rib. Like I mentioned earlier, the fascia of the serratus anterior, the fascia of the pectoralis minor, the fascia of the intercostal muscle, and then the fascia at the inferior aspect of the pectoralis major. The muscle is essentially left untouched. And this is the goal and gist of the surgery, where the blood loss is essentially minimal. And well over 99.7% of the time, the blood loss is less than 5 cc's. Now, going back to my patients that I've recently operated on, the same patient with the 700 cc implant and 650, she actually had what was pig mesh, which is the stratus. This is biologic pig mesh, porcine mesh that was used in order to reconstruct her augmentation. So initially she had the surgery. Because the implants were so big, they were malpositioned, and then she ended up 6 months later going to the surgeon, and he ended up reinforcing it with that pig porcine mesh in order to reinforce. So that was also removed. So the capsule is removed, inflamed tissue is removed, and also the mesh that is foreign body is removed along with the implant and capsule all as one system, such that none of that remains behind, or none of that it basically spills into the chest, if you will. Also, just yesterday I removed a set of ruptured implants, as you probably saw the Facebook Live, from the operating room. A lady 73 years of age that had implants saline, both ruptured. She had her augmentation done in 1977. This is like the time of Nixon, if you will, a long time ago. So 1977, and so these were her ruptured implants. From one was 10 years, and she recalled that the other one was a few years behind that. So those, no one should be living with ruptured implants, be it saline or silicone. Remember, they're not meant to be in the body forever. This is very clearly highlighted not only by the manufacturers but by the FDA as well. So this is very important. So these are the two patients that I just saw within today, and the one that I operated on yesterday. There was a patient last week who on Thursday, a week ago, 6 days ago, ended up getting surgery. Now this was a patient who was not able to come to me from California. She had saline implants from 99, and she had the implants underneath the muscle, a very average volume, 325 cc's. She had only 51 years of age. She had a lot of signs, symptoms of breast implant illness to the point where she couldn't walk. She was essentially wheelchair bound, and she was in bed most of the time. And unfortunately, having talked to her significant other, she ended up getting a explant surgery and also a lift in 2.5 hours, which virtually is impossible. This is from my experience, the gist and goal of the surgery, like I've mentioned before, is to remove that capsule plus that implant as one system, plus the inflamed tissue. There's a patient that I talked to just yesterday, and she is in Singapore, so she's going to be coming my way. She already had her explant in 2020, and she already had what was supposedly an explant, but continued symptoms of breast implant illness. So it's not only the capsule, but the inflamed tissue around that needs to be removed. So one looks at just the Facebook Live that I just did today, 6/5/2024, just a few hours ago, 3-4 hours ago. You will see that the left ruptured implant, the capsule is so thickened, inflamed, despite what is a textured implant that was ruptured. So all of that inflamed tissue in the periphery of that ruptured implant needs to be removed, because in it are the toxicities and the impurities, the heavy metals that have slowly leached out, certainly more so in what is a ruptured implant, and certainly, yes, in the textured implant intact, and certainly in the smooth implant and the saline implant. As you have seen the many times with the saline implant, when I touch the intact saline implant that I remove, there's a small amount of fluid directly around, and when I touch that saline implant that has just been removed along with that capsule, and I remove the capsule from the implant and I touch the implant and then I separate my gloves, you will see that gum sign, what I call the gum sign, where you see that the slime type of consistency on the glove, consistent with even the saline implant in itself, giving out particles of what is silicone that basically transfers to the periphery, to the capsule and the soft tissue around. Earlier this week, I operated on a patient that had residual capsules from 4 years ago. So she already had her explant done, and this lady comes to me with the many signs and symptoms of breast implant illness, despite already having had removal of her implant. And this is where her symptoms continue to persist. And then I went in and did removal of the residual capsule, and that was the essential goal and task of the surgery. And this goes on to show again that the entire capsule must be removed. We know this from the many patients who have explanted but continue to have the many symptoms of hurt of what is breast implant illness. You will see these patients, essentially there are two ways to confirm, and ultimately the definitive way is to ask the patient herself when she has had the residual capsules removed as to how she feels, and you will hear that the patient certainly have rebounded completely because the whole capsule was removed definitively the second time around, and it should have been removed initially. And the second thing is that pathology report in itself that essentially tells us the histocytic reaction, giant cell reaction, the implant particles that are embedded within, not all the time, in the pathology, in some of the pathology reports that highlight the significance and the importance of removing the capsule. Another patient that comes to mind is a patient I talked to yesterday from North Carolina. She already had her, from Tennessee, this patient from Tennessee, she had her explant already done, and when I looked at the pathology report, it was only 4.5 centimeters of that capsule, whereas her implant itself was registered as almost 14.5 centimeters. So there was a big discrepancy between the capsule that was removed and the size of the implant that she had, consistent with capsules remaining behind. And certainly she is hurting 6 out of 10 just to grade according to her subjective feedback. And now, depending on her schedule, she'll be coming my way for what is residual capsule removal. Now, what are the ways that one can check? And this is exactly what I did. You know, there's 5 criteria, if you will, that I say that kind of validate, authenticate, certify, or reinforce, or gives confidence that the surgeon did the right surgery. The first thing here is that the implants are returned to the patient. You want to make sure the surgeon's not going to rupture, or it's not going to rupture the salient implants, or it's not going to hurt the implants on the way out. Number 2, you want to make sure the diameter of the incision is essentially the length. The diameter of the implant essentially dictates the length of the incision, which basically means that if the implant is 700 cc's, you can imagine that the incision is going to be relatively wide, almost 8-9 centimeters. And that's what it takes, because remember, this is a very important point. When the implant is put, it's usually put, or dissection occurs up to 2 finger breadths below the clavicle, 2-3. And so now the implant, initially when the ladies get it, is riding up high. Now over time, the implant just bottoms downward and outward. So that capsule that's very much adherent and up there on the upper part of the chest needs to be removed completely, sincerely, just like where the implant and the capsule is at the bottom, even though the capsule is much larger. So the point here is that capsular tissue at the upper part needs to be absolutely removed as much as the capsule at the lower part. So one may have, like say, a 350 cc implant at the bottom, and this implant needs to be removed along with that capsule all the way up, stretching up to 2-3 finger breadths below the clavicle, wherever this capsule stretches still, because leaving that capsule behind, you're going to leave behind those impurities and the toxicities. So the diameter of the implant essentially dictates the length of the incision. Number 3, you want to have pictures and high definition videos of the chest wall showing complete removal of the capsule plus the implant, and cutting open of the implant and capsule on the table, showing that this was indeed very much done. There was a plastic surgeon from France who challenged me in a sense that he questioned the fact that I removed the capsule all the time, and I said, just look at any of those videos and the pictures, and that in itself highlights. If I didn't believe in that, I would likely be putting an implant, so I would be leaving or doing the surgery in a whole lot shorter period of time. On average, it takes me, and this goes to the next point, 4 hours. So look, today I didn't get done with my second case, which took a whole lot longer because the left side was ruptured. First case took the usual plus minus 4 hours. The second case was almost 5.5, 6 hours or so. And as you can see, it takes time to removing the implant and the capsule completely and sincerely. And there was one set of implants that both of these patients had along with their respective capsules. So it's not that there was a capsule above or below. And so it takes time. On average, it takes me 4 hours. And whatever length of time it takes for me to finish and do the surgery definitively, completely removing all of that tissue, that is the capsular tissue, directly on top of the rib, which is indeed what is the hardest part of the case. And so, again, the high definition pictures, videos, the length of the incision, which should be the diameter of the implant, the time of the surgery, on average 4 hours or so, plus minus. Majority of the times, 2/3, I would say I run over. Number 5, the high definition pictures, videos, and then the implants are returned to the patient. And 5, last but not least, very importantly, the surgeon must be very much accepting of what is breast implant. Unless nowadays we have a lot of plastic surgeons who want to be politically correct and say, yes, it does exist, it's a small number. No. Eventually, remember, all implants will need to be removed. Look, today, an 8-year-old silicone implant was ruptured. The other day, yesterday's case, the Facebook Live implant from 1977, 47-year-old implant had to be removed, that was ruptured from a couple of decades almost ago, like 10, 15 years. respectively. And so the point here is the implants eventually will cause the hurt. They will eventually rupture, and they will be causing the many signs and symptoms of what is breast implant illness. So that lady with the 8-year-old set of implants, she had the symptoms of breast implant illness, even though her physical exam was relatively very benign. No one can tell by looking at the symptoms if the patient has saline implants or silicone, and then the same set of problems that a silicone implant has, saline patients present with. And this is why when the ban of the silicone implant occurred in 1992, saline implants should have been banned because they cause the same hurt as the silicone implants. And the general notion is, well, saline is saline. Yes, the saline is benign and safe, but it's that silicone shell of that saline implant that causes the hurt. So going back to the fifth point, the surgeon must vocally accept that the implants are bad, and there is only one way to confirm, authenticate that the surgeon truly believes, is to not be, the surgeon should not be putting in implants. Because in order to put in the implants, it's a 45-minute to 1 hour procedure. In order to remove, like I said, it's a 4 hour, 5 hour, 5.5 hour, depending if they're ruptured or not, and a lot more of a challenge to remove and reconstruct such that both are going to be ultimately symmetrical. And so the surgeon must not be putting in implants. That automatically authenticates that the surgeon is a firm believer, because financially he's hurting. He would have easily put in 3 implants in the time it would take for him to explant. So that's a very important point. And not only that, so the 50%, the surgeon has to believe that he or she believes convincingly to the point where he or she is not putting in implants. And number 2, that the surgeon must be able to do that explant where he or she has a proven track record, and there is no other better way than to have the previous patients of that surgeon discuss and basically authenticate and basically confirm that the surgeon truly is removing the entire capsule definitively along with the inflamed tissue, such that the patient has the full bounce back. You should have that peace of mind that your surgeon did the right surgery, that your surgeon is a firm believer, and that when you put your head on the pillow that night, you have that peace of mind and that tranquility that you truly did get all of your capsules and inflamed tissue removed, and that they were checked and tested. There are many surgeons who do not, who look at that capsule and say, well, it looked benign. You cannot tell what it is or what it is not till the cultures are done for aerobic, anaerobic, and fungal, and till the specimen is sent to pathology to rule out the BIALCL CD30 analysis, rule out lymphoma, rule out malignancy, and then only then will one be able to have that confirmation that there was no abnormal pathology. It is underreported as accepted by the FDA and the Plastic Surgery Society simply because not everyone, the vast majority of the surgeons are not sending in the capsules to pathology. So the next question here is, let's talk about, if a person needed a lift prior to implant, reason why they got them to begin with, why would post-op the patient not need? Now remember, let's talk about someone who wants a lift. The patient does not have any implants. The lift operation alone in itself is a 3-hour operation. It's focused more around the nipple areola. So this one patient that had the mastopexy done through a nipple areola incision only, which is what they call a donut lift, where the incision is made around the nipple areola and a donut of skin is removed and the skin is essentially brought in. This is not a good lift. It does not last a long time, 3 to 5 years, and essentially what it does is when the skin is brought towards the nipple areola, it actually pulls the nipple down and decreases the projection. So not a good lift at all, and it cuts around the nipple areola. The lollipop anchor lift is in itself a 3-hour operation. This is a patient who has had weight loss, for example. Now, if a patient needed a lift before her implants, certainly she would need a lift after. There is no denying the fact. Because if someone is 65 years of age, the patient that I just saw, my last patient today, she needs a lift, period. Any person who's 65 will essentially need a lift, if you ask me, because what happens is postmenopausal, the patient's breast tissue atrophies. Just the fact that the implant is in the proximity of the breast tissue is in the proximity of the implant, the breast tissue atrophies with the estrogen progesterone down, the breast tissue atrophies with age, everything becomes smaller, and the elasticity of the skin decreases. And you will see with age, everyone will not only need a breast lift, but a neck lift, face lift, thigh lift, and essentially a whole tummy tuck as well. And the point here is, does everyone need one because they need a lift, or do they want one? And this is the question. Now, a lift is not a benign operation. I want everyone, don't listen to me, just go to YouTube or any other channel and see if you can look at a video where a lollipop anchor incision is done in order to do what is a formal lift. And as you will see, the cutting around the nipple areola, and then basically removing the excess skin, and then mobilizing the skin inward such that the lollipop anchor incision occurs in itself is a 3-hour operation. And majority of the ladies who have had this lift alone, there is no explant in this group of patients that I'm discussing. For example, you will see they will have pins and needles type of sensation. Not all of them, a good number of them, maybe 10, 15, 20%. Some of them will not be able to nurse, for example. Some of them, let's say you do not want to get one and the next year you plan on getting pregnant, for example, because that in itself will engorge the tissue and essentially mask the lift, you do not want to get, or someone who is planning on a massive weight loss. Going back to the point, the self-monthly breast exam to look for breast cancer, 1 out of 8 or 9 women in the United States will get breast cancer, and now you have altered sensation, you have scar tissue because it may be because of the suturing, or it might be fat necrosis, which sometimes inevitably occurs depending on the size of the patient. And you will have what is an altered self-monthly breast exam, and now a mass might get missed, or a mass might need unnecessary biopsy simply because it's inconclusive on physical exam or a mammogram or ultrasound or MRI. And the point here is a lift is not a benign operation. Now, I have myself offered patients, even though they did not ask me, a lift and an explant, and it took me the 7 hours because the explant itself, the dissection off of the rib, took me almost 3.5 hours, and then the lift operation in itself takes that longer period of time in order to dissect and suture, because this patient had significant hypertrophic scars around the nipple areola and inferiorly, and the anchor incision. And I truly felt that she would benefit from removal of those keloid scars, and I myself offered it to her despite her not even asking. So a lift now I have heard, there is amusing, some of my listeners or the other Facebook owners have suggested that I do not know how to do a lift. I will tell you, a lift is a very basic, benign, easy operation. It's a top probably 5 most common operations, be it a breast reduction or a lift operation, mastopexy, that's what it is called. It is a very simple operation to cut around the nipple areola and then mobilize the tissue upwards such that from the sternal notch, the distance is symmetrical on both. But this is where you do not want to, number one, going back to the question of the lift, in vast majority of the patients. So tomorrow, I'm going to actually interview a patient of mine. She came from Florida, and she had both ruptured implants. And you will hear from her own words. She is a patient that accompanied my other patient who I operated on yesterday. And she's going to talk about her surgical experience with me a year ago in 2022 when she had her explant done. I did not use drains, I did not do a lift, and she had both ruptured implants, both of them. And I actually did a Facebook Live directly from the operating room. And we'll hear directly from the patient that she did not need a formal lift. So number one, patients, 80% of them from my experience do not need a formal lift. Now, if you needed a lift prior to augmentation, very likely, as you will see, you'll only need a lift afterwards. So number one, going back to the point why I do not do a lift. Number one, a lift may not be required. The patient will get away with, look, I already told you the 700cc implant patient, I believe her age is 46. She did not need a formal lift, and I just saw her post-op day number 6 today. Or we'll hear from the patient. Number one, you do not need one 80% of the time. Number two, I cut out the excess skin from the bottom. That really helps pull the tissue inward, and I put some internal sutures that helps medialize, which means pushes the breast tissue upward and inward because it has been dragged down just upon the sheer weight of the implant. And number three, the recoiling of the skin and the breast tissue occurs over the next several weeks and months. And now between the fluffing effect and between the 10% muscle mass that the patient adds when they do work out in the gym afterwards, that ultimately leads to a very good aesthetic result, minus the unnecessary scars around the nipple areola, minus the pins and needles, minus the altered physical exam, minus the scars that are very visible. I've seen many patients within the last few months that have had very prominent hypopigmented, meaning white scars around the nipple areola, aesthetically very displeasing to the eye, minus the pins and needle, minus the loss of sensation, minus the pain. The other thing I want to talk about, so this is essentially the lift operation, and you do not want to be on the OR table for 7 hours unnecessarily. Now, every patient of mine will get a heparin sub-Q shot so that the patient does not have the risk for DVT. Now remember, between the twilight sedation, between the sitting out of bed into the chair on post-op day 0 and the following day walking, between the heparin shot, between the sequential compression devices, which are the squeezy boots on the legs, the risk for a clot is essentially minimal. And so those patients that travel to me from far away, their risk for a clot is essentially non-existent. And I have had, and I'm blessed to say, and honored and humbled to say, that just this year alone, I have had patients come to me from India, from Germany, from Italy, from New Zealand, from England, from Iran, again, certainly from Canada. And I'm very blessed to have a large following, not only within North America, but from Europe and far away. I also want to go ahead and take time here to very importantly mention that I have donated $0, not even a cent, to any Facebook groups, private groups for Facebook owners to market me into their respective groups. This is as organic a group can get. This is where I say every explant surgeon must and should allow, and this is what I propose to the many patients themselves. Because remember, this website, this Facebook page was created by a patient of mine, and I will tell them, and I told her, and I told Alyssa, who made the Facebook page, that I do not even have a Facebook account. So she created my Facebook page that I still don't follow on a regular basis, but every once in a while I get alerted to it if there is an important case that I need to discuss or important point. I have taken $0 contribution from someone who would want to advertise themselves, take advantage of my platform, or vice versa, where they would want me to take advantage of their platform. It is wrong and unethical and unprofessional to basically get promoted on another Facebook group for financial reasons when the other Facebook group owner does not have any medical knowledge, scientific knowledge, has never stepped into the operating room, is not even a doctor or a nurse or a surgical tech to be able to weigh in on and authenticate a surgeon's performance in the operating room by financial reasons alone. And this is a Stark's Law violation, if you will, to have an incentive gain, divert traffic. And this is not what I would call marketing. This is called false advertisement to promote non-professional surgeons who do not do the right explant surgery. Because remember, this is the worst case scenario for our patient to undergo surgery, and then she has to come back to the operating room for residual capsule removal to complete the surgical job. Now, what I want to do here is I want to be able to answer some of the questions that you may have. So I'm going to go ahead and scroll up and down. Feel free to ask any questions. What I'm going to do is let me go ahead and see what questions others may have. Please feel free to ask. How long after an explant can someone have a mammogram? Now, I say to the ladies, wait 3 months. This is when the swelling has come significantly down, and then you're able to get a mammogram without any pain, without any hurt, without any trauma to the recent reconstruction. If you feel comfortable at the 3-month mark, then certainly at the 4th-month mark, I would say well over 95% of the patients should feel comfortable. You will be surprised how many patients have come to me where their self-monthly breast exam was benign, but the mammogram picked up on breast cancer. Remember, 1 out of 8 or 9 women are going to get breast cancer. So if I were to operate on 100 ladies, in their lifetime, 12 of them will get breast cancer statistically. So I do not want to miss, and that's why I specifically ask. And this is part of the medical clearance, which means that the doctor has given clearance to proceed with surgery because the patient does not have a mass. I want to mention a patient, very nice patient, coming from out of state. She had breast cancer, and the surgeon, the breast surgeon went in order to remove the breast cancer, and there was a few millimeter margin. I told her, go back, get a second opinion, which she did, and she got her second surgery to remove the residual, i.e. breast cancer that she had, and now she's going to be coming to me in the latter part of June, where I will go ahead and then explant her now that she is essentially cancer-free, and then she will eventually end up getting her radiation. So the point here is we want to make sure that breast cancer is screened appropriately and picked up early, and so that when I do operate, I do not want to be dealing with any irregular or unknown masses. So the second patient that I did today that had the ruptured left breast implant, there was a left chest mass that I removed. Clinically, it looked like a pathologic lymph node, separate and in around the lateral aspect or towards the side. I said it separately because I know it's inflammation given the rupture, but I want to make sure it's not any malignancy like breast cancer, the BIA, which is the breast implant associated squamous cell cancer, or the BIA-LCL. Remember, it is very rare to get the BIA-LCL. To date, there's approximately 1,233 cases. Now, this is very much underreported. This is acknowledged by the FDA, by the plastic surgery societies, because no one is sending the capsules off, and this is essentially being missed. Hopefully you're finding all of this informative. Now, another patient that I talked to, she had basically a rupture. So she had multiple implants. The second implant that she had ruptured. It was a silicone rupture, and then she got another set. So I want her to get a MRI with and without contrast, if and when given clearance by her primary care doctor, because I want to pick up on any of those silicone granulomas, that's free-floating silicone, that she very likely has, so that those pockets of silicone I can remove along with the current set of implant that she has, because all of it is not going to be essentially contained. So the point here is, in her case, because she has a history of free-floating silicone, given the second implant that she had that ruptured, her third implant will be removed along with the capsule and implant, and that free-floating silicone will ultimately be removed by me, such that any of those pockets I will physically go after. Now, I will palpate, visualize with my eyes, I will look at it, and if my sixth sense tells me this is abnormal tissue, it's hard, irregular, abnormal, plus the MRI in itself will highlight these areas. then I will go ahead and have a better roadmap along with confirmation by imaging, such that all of that silicone that had spilled into the chest would be ultimately removed, because that is what it entails. So another important point here is one patient had a set of implants above. So this is a patient I saw on Monday. She had a set of saline implants above the muscle, a second set below the muscle. And then on the left side, the surgeon used mesh, because I saw the operative note. So in her, I'm going to remove the residual capsules from her first set of saline implants above. So specimen number 1, specimen number 2, right and left side respectively. And then I'm going to remove the implant and capsule below the muscle, her current set. And then I'm going to remove the mesh that was used primarily on the left side as dictated in the operative note, so that all foreign body is removed. Any abnormal suture like Athabond permanent suture I remove. Any surgical clips, for example, during a cancer operation, I also remove, because there is no reason to have a foreign body within, especially if it's in the operative field. Remember, clips are used all the time routinely, but if they're encountered, there is no reason to having them in the proximity of maybe what are vital soft structures like nerves amongst other glandular tissue. Now, the Athabond suture, for example, this is a braided green suture. You can Google it, Athabond. It is a permanent suture, and it causes some granulation tissue to form around a scar tissue, and that's why it needs to be removed, so that when the patient gets her self-monthly breast exam or does the mammogram, we're not going to be picking up on these irregularities or scars. Now, the next question I have for the patients is, how do you know you have breast implant illness? Now, this is, essentially where you have a questionnaire that essentially lists the many problems the patients have related to the implants, anywhere stemming from the head all the way down to the toe. And I'm just going to go top down. This is hair loss. Some patients report a lot of hair loss, headaches, migraines, personality changes, anxiety, depression, panic attacks, suicidal ideations, thyroid problems, neck and back pain, fibromyalgia type symptoms, dryness of the eyes, vertigo, tinnitus, ringing in the ears, throat trickle, inability to swallow completely, dryness of the mouth, dryness of the eyes, as I mentioned earlier, not able to smell, for example, a strawberry, altered sensation. You have difficulty breathing, arrhythmias, palpitations, for example. You have the trapezium strain, fibromyalgia-like type symptoms, the rheumatological joint problems. How many patients did I see in the last week where they went to the rheumatologist, the ANA was elevated, but the rest of the exam was not consistent and suggestive of rheumatoid arthritis? You have patients with GI disturbances, irritable bowel syndrome. You have patients with endocrine, thyroid, adrenal issues, for example. You have patients with joint problems. The hallmark feature, again, are the joint problems. The most common symptom is fatigue, where patients, after having slept 8-10 hours, would sleep another couple of hours, or they don't want to get out of bed. Brain fog, also very common. Short memory span, very, very common, where patients don't remember why they left the house, what task they were going to do. And plantar fasciitis, that's the irritation, i.e. inflammation of the fascia at the sole of the foot, amongst the many other symptoms, including premature menopause, and connective tissue disorder, scleroderma. So now if you have a patient, one of the patients went last week, she had already seen the allergy immunologist, cardiologist, rheumatologist, endocrinologist, and these are patients, as you will see, they will attest to on the private breast implant illness support group page. They have been to all the doctors, and none of them point towards what is breast implant illness. So that patient from California who had her 2.5-hour explant along with that lift, which was an incomplete operation, she had spent 8 days at the hospital, and they were seen literally by every subspecialist. And the consensus at the end of the discharge was, you are fine, everything is good. You probably got stresses in life, you're perimenopausal, you're 51, and the bottom line here is, this is BII till proven otherwise. The most important thing is, that the patient has been tested. She does not have any arrhythmia. She does not have any heart problems, and no problems such as thyroid problems. Now, during the workup, if the patient has low thyroid, that patient has to have that thyroid corrected, because hypothyroidism will mimic breast implant illness. The fatigue, the dryness of the face, skin, eyes, hair loss, weight gain, joint problems are all symptoms of hypothyroidism. But if someone has a normal thyroid, that speaks against and speaks for what is breast implant illness. Now, the only ultimate way, there is no lab test, no imaging, it's this questionnaire. If you go to my Facebook or my web page, you will see this questionnaire pop up, and where you can check the boxes, and you will see a young lady, 25, with no major medical issues on no meds, circling 20 of these problems, again speaks for what is breast implant illness. Sometimes it may occur within a year. So I have a patient from Georgia, and I operated on her. She's the one I did the Facebook Live a couple of months ago. She had 1,140 cc implant on the right side and 1,000 cc implant saline on the left side with an extensive alloderm. And her pathology came back as fat necrosis, inflammation, giant cell reaction, amongst the many others. As you can imagine, her post-op course was very involved, extensive surgery done, a lot of inflammation. And the point being, these are patients this is the patient who just had her surgery in August of 2023 after having right breast cancer, the DCIS. And the point here is, these are not benign cases, or these are not benign patients. These patients are hurting. But the bottom line is, the patient was vetted, and a sincere attempt was made in order to free up all of the alloderm foreign material such that no inflammation was left behind. Now, this patient is having some fluid buildup, and she requires further workup, and I will make sure that she basically gets that attention so that she ultimately gets this addressed definitively. The most important thing is there was no breast cancer found on the mastectomy scars. There was fat necrosis, so that pain is gone. And post-operatively, ultimately, when she is all settled and done, this implant nightmare, if you will be all behind her, if you will. Now, going back to the point, someone has low iron, that will mimic breast implant illness. Someone has vitamin B12 or other vitamin deficiencies, for example, and they're quantifiable within the blood workup, then the patient needs to supplement and normalize those numbers, because that should be true for any patient regardless of the surgery. Now, next week, when I have my patient that I operated on a year ago, 2023, that is accompanying my patient from yesterday, she and we will have a sit-down discussion where I will ask her questions. She is, what I will say, an expert on insurance. So we will have her talk and discuss her experience as far as working with insurance. So hopefully you will find that informative. Now remember, this is very sad to say that the FDA, the government, and the system, and no one is wanting to recognize this breast implant illness as real. Is we clearly know the implants have been banned. These newer set of implants, look, the implant, the gummy bear, this should not have ruptured. It indeed did rupture. You know, you hear about someone driving their F-150 over the implant. Look, that implant, as you saw a few hours ago, that I removed on the left side was ruptured. These implants are not safe. Yes, they may be gummy bear, which is a very nice marketing tool. Ultimately, they are going to rupture and disintegrate, just like this one and the many others that I removed that were reintroduced into the market after 2007. And the point here is that the system, that is the ICD-10 code, there must be one. The insurances must cover it, and there should be a general consensus as to what is the goal and ultimate direction of the surgery, which is to remove the entire implant, capsule, all of that inflamed tissue, and to get it tested to make sure absolutely that there is no badness behind. So we will hear anyone who goes to a doctor where the insurance covers the explant, that cannot be the complete explant, period, 100%. no insurance is going to reimburse $1,200 for what is a 4-hour surgery. This will be a recipe for Chapter 11 bankruptcy for the surgeon, because you cannot justify being in the operating room and only getting compensated plus minus $1,200 or so. And the point here is that the insurance does not want to even recognize breast implant illness because there is no code. They say that because you got it for cosmetic reasons, all the cost of Explant must be covered by the patient. And number 3, when they do cover it, they don't even want to recognize what is a total capsulectomy, because they say, who told you to remove the capsule? What's the indication for that unnecessary capsule removal, which is essentially the heart and essence and gist of what is Explant surgery. So now please go ahead and ask any questions. I will go ahead and continue to now this red light therapy. I will tell you, this is a very trendy thing. There is no scientific evidence to this red light therapy. Personally speaking, there is nothing in my training as an MD, as a physician, that I know of where there is mention or discussion of red light therapy to help with the symptoms. Otherwise, everyone should be getting it if you ask me, because everyone's kind of stressed out. Certainly I would be the first one to do it if I believed in it. And the bottom line here is there is no validity to it. There is no scientific evidence to it. And, if this was true, everyone would be getting it, including the president. That was a joke. Anyways, let me go ahead and see. If there's any other questions. So there's this whole concept of, I get this question asked a lot, this detox phenomenon. I'll tell you, there is no, and this is related to this red light therapy. Charcoal, for example, is this is given in medicine for those people who ingest poisons or toxins in order to have them basically poop it out, if you will. This is where the charcoal binds to the chemicals. It's not going to leach anything from the blood. You will also see that there is mention of vitamin C. Now, if someone takes an orange a day, that's good enough. There is no reason to supplement with pills. Sometimes I've seen patients with vitamin C toxicity because there is a lot of that given. Remember, all these supplements are not validated. They are basically made in China or South America. There is no concrete evidence that whatever the bottle states that what is inside, it's not regulated by the FDA or the agencies. And we do not know, we do not have any proof that what the patient is taking is real. One patient came to me and she had a potassium level very high, and it turns out it was in the supplements. Some of the supplements can cause blood thinning, and which is not safe or healthy around the time of the surgery. So very important to that belief and the trendiness of these supplements is not the detox or the cure, if you will. If that was the case, I would certainly mention. Now myself, I'm a biochemist in my training in undergrad. I did then my medical school training. Following that, I did 5 years of general surgery, and I'm a board certified general surgeon, having done a lot of colon, small bowel, gallbladder resections, and all the gunshot wounds to the face and chest, and managing the patients with the different aspects of general surgery. Then I did 2 years of burn surgery, research on Integra. I did a burn fellowship in those 2 years, and then research on Integra, which is artificial skin. And then I did 3 years of plastic surgery, and now I'm a board certified plastic surgeon. One of the patients I talked to from British Columbia last week, was asking if I'm board certified or not. Every person must be board certified. Every doctor you talk to must be board certified. And let me go ahead and show you the ASPS logo. This is the only this is the only one plastic surgery society that authenticates and certifies. It is this logo that the patients must see on a surgeon's website that confirms that the surgeon is trained right, has the professionalism, has the integrity, and continues to be in that select group of surgeons who basically are ethical, have the right training, and have the professionalism into doing the surgery. Remember, you may be the world's best microsurgeon, but if you don't believe in breast implant, unless you're not going to do the right surgery. If you have not done enough of these, remember, this is tricky surgery. You're not going to be able to do it proficiently enough on all these cases. Like this last case with the rupture implant, it was very tricky and took well over 2 hours. The one thing that I want to mention is I want the patients to do their homework. Talk to the previous patients of that surgeon, and then get to understand what the surgeon is thinking. The surgeon must have a track record and a very clear check and balance. I propose this to the many, and this is what I was trying to say earlier. I propose to the many ladies who will establish feedback groups within a Facebook group of surgeons so that the previous patients can talk about those surgeons and get a valid real life feedback, so that I'm in check, other surgeons are in check, and that as the surgeons continue to operate, they themselves are validated by the previous patients and the current patients, so that the surgeon continues to do the right operation. This is, for example, on my Facebook page, if there is, God forbid, any issues, it will get surfaced, it will get mobilized, and people and patients will private direct message. This is important, especially in the world of explant surgery. If someone needs to get a gallbladder out in Texas, California, Massachusetts, New York, Florida, it's the same way it's done. However, if you go to 10 different or 100 different explant surgeons, and nowadays you have every other surgeon claiming to be an explant surgeon, you will see 100 different answers. Majority of the surgeons are fixated on a lift, as the patient I said earlier. They basically overly use the word and improperly use the word en bloc, where a partial capsulectomy would have been the right choice for those surgeons. The right answer is en bloc or 100% total capsulectomy and nothing else. This is where the patients should then, in their own interest, with no financial feedback, I want the patients to validate all of us, including myself, so that there is a genuine page that basically yields objective, non-biased information about the surgeon. And the only goal for the surgeon should be to help the patient and not to financially gain out of someone else's, quote, misery of breast implant illness. So this is something that I propose to someone who would take on the initiative. I just want to mention there was another patient that mentioned that you were in the top 10 list of plastic surgeons who explant, and I'll tell you that list was made by someone who is not a surgeon, who's not a doctor. It was just someone who just chose to write an article and probably inflated another surgeon who just wanted to get more patients and used the other surgeons who are more notable in the groups so that they would get validated just by being in the proximity of those other 10 surgeons or 8 surgeons, if you will. So you want to be very careful what you read and see, because there's a lot of misinformation and misinterpretation of information and a lot of financial influence that drives these patients, unfortunately, many of which do not comprehend. I will tell you, the first day or 2 or week, it can be a challenge to grasp this concept. But if you follow, for example, my Facebook page, and I tell my patients that come to me, you're not making a decision, you're making a understanding and informed consent. And once you have enough data, information, be it a year later or 6 months, then you can reach a decision, because now you have the knowledge and the power to make that decision, such that when you come to me or anyone else for the explant, you're excited about the explant and that you feel very content and happy to be moving on and improving your health and freedom from the silicone toxicity till proven otherwise. I tell my patients no guarantees till the surgery is done. I do all the surgeries in the manner that I do. Remember, I only do 6 or 7 or 8 of these in a week, so there's not a whole lot of the surgeries that I do. I know my patients very well. From the beginning of the week till the end, I'm super busy just talking to my patients, getting feedback, looking at medical clearances, talking to the patients, as you all know, so that I want to make sure that when you come to me, you have been vetted not only by me, you've been cleared, but also by my anesthesia team independently, and certainly by your doctor as you come to me, so that there are no surprises. Let me go ahead and see. I'll answer. Is that shot the bruise we get on our left side? This is the heparin shot, by the way. This is where, for example, someone gets admitted to the hospital. They give the heparin shot 3 times per day because they don't want the patient to get a clot. So this is, you're going to see on the flank side, a heparin shot like a bruise, and this is the heparin shot for the DVT prophylaxis. You know, let me go ahead and look. Can an abdominal CT scan damage the implants or make them do more harm? Now, a CT scan of the abdomen is a lot of radiation, and you know, the CT scan has not been shown to hurt the implant per se, and so there's no documentation of it in the medical literature. You know, CT scan obviously is a lot of x-rays, if you will. It's a very fancy high radiation study to look at structures within the abdomen, done very fast with or without contrast. Now remember, if you will, to look for the silicone implants. So a patient came to me and she said, I had a MRI of the chest done and I have saline implants and my implants are intact. I will tell that patient, and I told her patient yesterday, you do not need a MRI to look at saline implants, because the saline implants, when they do rupture, they rupture completely like a water balloon and they collapse completely. So you will know that the chest is completely deflated as opposed to the other side. Unlike silicone implants, you could take a needle and poke it 10 times and it will retain its shape simply because it is relatively viscous. It's going to be contained overall and it's not going to deflate like a water balloon. So the CT scan essentially is irrelevant or not harmful to the implants from what we know from what I know from the medical literature, and certainly can be harmful to the abdominal structures. You do not want to get repeated CT scans. For example, as you will see in a pediatric emergency room, they will not get CT scans on kids because that is very harmful radiation, bad radiation for the kids. Very important point. I saw someone advertising like a pan CT to look for a ruptured implant. I will call that malpractice. You cannot do serial CT exams looking for a rupture. An MRI without contrast is a study of choice. MRI is magnetic resonance imaging. It's magnetic waves. It is no contrast and there's no radiation involved, and so essentially it's a relatively benign study. There is no contrast to look for a rupture. Let me go ahead and look at what is the average recovery time frame. So remember, the whole surgery and the vast majority of the patients, when the implants are below the muscle needs to relax and the muscle needs to settle. And I'll end with this question. Now, as you can imagine, the pectoralis major muscle, and this is the question I got asked by the nice lady from Singapore and the lady today. As you will see, the pectoralis major muscle is the muscle that you will see here if you will, this is part of the cadaver, the chest area. And as you will see, the lower part of the muscle, if you will, let me go ahead and find a pen. So I'll just use my finger here. So the lower part of the origin of the muscle is here at the sternum, and also at the lower part of the chest. When the surgeon cuts the lower part of the muscle in order to put the implant underneath the muscle in itself will window shade up, retract, recoil, because as you will see, the muscle itself inserts into the upper arm, the humerus. And so what happens is the muscle window shades up. So if you will, now I'll use my hand. So if the muscle is here and the surgeon cuts the muscle at the bottom to put that, and this is the implant, to put the implant underneath, the muscle lifts up and the implant truly cannot be covered by the muscle inferiorly at the bottom. And so what happens over time when the muscle is covering the superior, the upper part of the implant essentially over time just moves down and outward. And if you contract the muscle, you will see that if you contract the muscle, it's going to push it down and outward. And so the majority of the implants fall downward and outward. Now, once the implant is removed, the muscle is already being cut. This muscle cannot be used to move it down and basically reattach to the origin. In some cases, I'm able to do so if the patient has a small implant. And the goal here is to absolutely repair the muscle for two reasons. Number one, anatomically, the patient has good function because the muscle is used to lift up objects on a day-to-day basis, and also the strength of the shoulder, if you will, because of the way the pectoralis major muscle works, the way it's inserted into the humerus. And then also for aesthetics, it also allows for recoil of the chest breast area, so it actually does a recoil of the breast tissue itself. Now, how many times have I shown that the muscle repair is done by, for example, the breast cancer patients where they have the tissue expander and the muscle is preserved, and so I make the cut right in the middle, remove the implant, and I repair the muscle absolutely, because the patients are very much dependent on that muscle. But if a patient has, let's say, a big implant and the muscle has moved up, you cannot take the muscle and then reattach it back to its origin simply because it has contracted, or over time it basically gets attenuated. And this is very clearly established by not only I, but many other plastic surgeons who will essentially see this same. There are many surgeons that cut up and down from the nipple areola. Now that's a different surgical incision and cutting of the muscle that sometimes inevitably occurs, and that muscle indeed needs to be repaired very sincerely and definitively, such that there is no compromise of the muscle function. Now, the 3 weeks to 6 weeks later, the muscle essentially settles onto the chest, and then vast majority of my patients at the day 42 to day 45, that's 6 weeks out, I have them gently start weight training 1 minute in the morning with the 2-pound weights and 1 minute in the evening. When these two start working out, they now actively build not only the pectoralis major, but the pectoralis minor, the serratus, the deltoid, the trapezium, the suprainfraspinatus, the entire essentially muscles of the neck, back, shoulder, such that when the patient is able to now post-op a few months later after working out, the second week doing 2 minutes 2 times per day with the weights, third week doing not only 3 minutes but 3 times per day, you will see 3 months, 6 months later, the patients have added muscle mass to their chest, their posture is better, they got better strength. Remember, all these times where they were using their upper extremity, they were compromised because the implants would move or they would cause that hurt and inflammation. Now they're able to build on that muscle mass, and they're now able to exercise much better, they're able to play sports better, and essentially you gain that function not only out of what remains of the pec major, but the pec minor and all the other muscles of the shoulder, neck, back, which were compromised as a result of the implant. There is a good subset of plastic surgeons who choose to place the implants above the muscle, and I see that in itself has a whole set of problems in itself, including higher rate of infection or capsular contracture, among others, among bottoming out. And so that in itself is also, consistent with operative problems. A good plastic surgeon should not be putting in implants, period. So having said this, I want everyone to learn, talk to the previous patients. I find that an excellent source and tool for the other patient, the prospective patient, to learn from the other patient's experiences. The Facebook is an excellent tool, as the many ladies attest, learning and educating themselves. It makes my life easy that the patient is well read and understood and understands what is the post-operative course going to be, such that it leads to less problems. And this is where it is important. The best patient is the one who's educated, who understands the risks of the procedure, and who basically is well read, such that post-operatively they're able to better manage with what is this very well tolerated outpatient procedure. Now, hopefully you found this informative. Please share this information. I just saw a question. So if the implants were implanted through the armpit, is it the same cut? Yes, it is, because it is the same cut at the bottom by me. And when the surgeon puts in the implant, it is essentially the same cut at the bottom that will allow for the implant to sit below the muscle if this is where the implant was placed. Remember, vast majority, all the cosmetic patients, their surgery is done essentially in 45 minutes to an hour between the two sides. And the implant is literally, if it's below the muscle, literally falling down, or if there is no use of mesh or Galaflex, it essentially is hanging down below and over time just sedimenting downward and outward, what I call bottoming out. In those patients with breast cancer, the muscle is here, the surgeon cuts the muscle, if you will, and puts in the tissue expander and then closes the muscle, and then every month she goes to the the plastic surgeon, and then they put in 100 or 150 or 70 cc's till the muscle gets tight, and over the next 4 to 6 months, as you can see, the tissue expander is enlarged, and now the muscle is covering the implant. And then what they do is the plastic surgeon then goes back in, removes the tissue expander, and then puts in the implant. So this is a very quick, easy fix of the muscle, because the muscle has been expanded. In the cosmetic patients, this literally occurs over 45 minutes to an hour. The muscle is cut. And remember, when the muscle is cut from its origin, it just retracts. And this is where, no matter what the incision, from the belly button, horrible incision or a horrible choice, from the axilla, not popular, because remember you got bacteria, whatnot else that ultimately might seed. It was a very popular choice back in the day, not routinely done. Through the nipple areola, also a very bad choice to make an incision, to put in saline or silicone implants, because you don't want to cut around the nipple areola and the nerves and the ducts and the breast tissue, and then to go below the muscle to put the implant. That's a very poor choice, because now you're cutting all these vital structures, plus the scar on the chest, plus the altered nipple sensation, plus sometimes some patients have difficulty nursing. For example, if they're young patients who got implants, the surgeon who chooses the incision at the lower part of the breast is the better, smarter surgeon. Obviously, the better, smarter one is the one who's not even putting in implants. So there you have it. Hopefully you found this informative. Next week on Monday at 10 p.m. we have the local channel 3 that's going to basically broadcast my interview that I did with one of the local channels here in Michigan. I'm going to record with my patient tomorrow a question-answer session from one of my former patients from Florida. We will post this hopefully next week or the week after. And please stay tuned. Hopefully you found this informative. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. Thank you again very much.